Welcome back to the studio, and thank you, Dr. Kluge, and to our esteemed guests for so clearly illustrating the megatrends and their impact on health and well-being in our region. And thank you to our participants for joining us for this inaugural public hearing on tackling non-communicable diseases and advancing mental health. I am Alison Eckberg, Technical Officer for Non-Communicable Diseases, and I will be co-moderating today's session. As you know, this is looking at the interplay between the megatrends, as you heard in the earlier segment. And we have an exciting agenda planned, beginning with some special opening messages, a keynote by Dr. Gauden Galea, a panel of speakers, and of course, a breakout session where we really count on you to share your ideas about how we can shape our future rather than just react to it. With that, I will give the floor to my co-moderator.
Good morning. Thank you, Alison. Thank you, Dr. Kluge, and thank you, everybody. I'm Lydia Lazari, the Regional Advisor for Mental Health in the WHO Regional Office for Europe. And like Alison, I echo how excited I am to hear to the pan-European health community about the future that we can shape together. I have the privilege now to give the floor to a video message by President Alar Karic from the Republic of Estonia. If we can have the video, please.
Dear European healthcare community, in many of our countries, we see rising rates of anxiety, depression, and sadly, suicide attempts, especially among young people. Providing these people with quick and adequate care will be one of the major challenges to our primary healthcare systems. But it would be terribly short-sighted to only focus on efforts on that. For too long, we have been keeping one's mind on treating mental health problems after they emerge, when the human and economic costs are already high. The old truth that prevention is more cost-effective than treatment has never been more accurate. Prevention does not just mean equipping people with the tools and skills they need to maintain their mental well-being. Prevention also means creating supportive environments in schools and workplaces, building community resilience, and addressing social determinants of mental health. We must address mental health together with the causes of other major non-communicable diseases, as these are also often risk factors or outcomes of mental health issues. But above all, we must acknowledge the deep interconnection that mental health has with many other societal challenges, from climate change to geopolitical tensions, from technological disruption to growing economic inequality. These challenges do not exist in isolation. They amplify each other, creating a complex web of stressors that affect our collective mental well-being. When young people face economic hardship, they are more vulnerable in climate anxiety. When communities are disrupted by conflict, their resilience to other challenges is diminished. Understanding these interconnections is crucial for developing effective responses. However, we must be cautious not to embrace simplistic solutions. For example, while it may be tempting to blame social media or smartphones for mental health issues of young people, reality is more complex. Our approaches must be evidence-based and respect individual privacy. We need nuanced, comprehensive strategies that address root causes rather than symptoms. To achieve that, I propose that mental well-being must become a fundamental consideration in every policy decision we make, from finance to education, from urban planning to healthcare. It must be our target to create environments that actively nurture and support the mental well-being of our citizens. It is fundamental to the resilience and prosperity of our societies. Thank you for your attention.
Thank you very much to President Karis for his wisdom and sustained commitment to support mental health. This is not the first time that President Karis gives a support to mental health. I echo his inspiring words at the meeting of the Pan-European Mental Health Coalition more than 2 years ago. And President Karis, thank you. You remain committed to mental health. Thank you so much. Now I have the pleasure to introduce a message from Michael Bloomberg, the WHO Ambassador for Non-Communicable Diseases and Injuries. If we can have the video, please.
Hello, and let me thank Dr. Tedros and the World Health Organization for bringing everyone together. Around the world, there's a life or death issue that national governments don't focus on enough. It's the urgent threat posed by non-communicable diseases, or NCDs, such as diabetes and heart disease. These diseases are the leading killer in most countries, and without bolder action, millions more people will die prematurely over the next decade. At Bloomberg Philanthropies, we're always looking for opportunities to help people live longer, healthier lives. Our global work began nearly 20 years ago with tobacco control, and we've taken on NCDs through my role as WHO Global Ambassador and through a more than 70-city network called the Partnership for Healthy Cities. We've made major long-term investments to reduce tobacco use, promote healthy diets, and prevent cardiovascular disease. And we've seen some encouraging progress, but not enough. This convening comes at a critical time ahead of this year's high-level meeting on NCDs at the UN General Assembly. So thank you for your leadership and your partnership. By teaming up to tackle NCDs, we really can save and improve an awful lot of lives.
Thank you to both the contributors, and I have now the pleasure to go back to the person that championed for the last 5 years non-communicable diseases and mental health in the WHO Pan-European region. So, dear Dr. Kluge, dear Hans, your comments about...
Thank you. Thank you, Lydia and Alison. It was wonderful to see President of Estonia and Ambassador Bloomberg. Indeed, we're starting with the first hearing, the silent epidemic of NCDs and mental health. Why? Well, most of us will, let's say, pass away at one stage due to non-communicable diseases. We used to call it also chronic diseases. But there the drama is that it happens prematurely, right? It happens far too early. And the good thing is that we know what are the risk factors. I mean, most of this is preventable, right? It's about the tobacco, it's about the alcohol, not enough physical activity. Both of you know that I'm biking every day here in Copenhagen to the office, right, instead of the car, and also healthy food. But for this, we have to be very brave. We need political leaders, civil society partners to tackle what we call the commercial terms of health. And there I want to commend our own director, Dr. Gordon Galea, champions like Deputy Prime Minister of Belgium, Frank van den Broeke, who launched under the EU presidency this first ever report on commercial terms of health, right? We say it tackles, basically to tackle it, we have to look broadly. I always say men die younger, but women suffer longer because they are living longer. Mental health, Lydia, as we discussed often, right? I'm very concerned, 28% of the 15-year-old girls, 14% of the 15-year-old boys are telling that they feel lonely most of the time or always. I always say loneliness is a killer. And again, the answer is there, as we heard. Social connection. No one is an island on itself. So I'm very excited to be part throughout the whole morning of this first hearing and hearing many innovative ideas, because this EPW2 has to be owned by all stakeholders, and particularly which difference it will make for the people.
Thank you so much, Dr. Kluge. And yes, it is absolutely essential that we look at how we can work together collectively to remove these barriers to good health. Now, to set the scene and to provide an overview of where we are as a region and to inspire us to think about how we can collectively address our unmet commitments and achieve a region that is both better prepared for the challenges ahead. We would like to introduce Dr. Gordon Galea, Strategic Advisor to the Regional Director for Non-Communicable Diseases and Innovation. Over to you, Dr. Galea.
Can you hear me now?
Yes, we hear you. Thank you so much.
You can hear me, and can I just see if I can share my screen, please? Because there are multiple things we are doing at the same time. So let us go here and
Yes. He'll do it, his thing. There we go.
can I check what you are seeing? Is it the whole screen?
We see a bullseye. I can't tell if we see.
I will stop sharing. For some reason, it will not allow me to just show the, as it usually does, it will not allow me to just, let's see here. Okay, is this working now?
Yes, now we see your screen in full.
Yes. Okay, a technical moment is necessary when things are being done live. So greetings all, and I'm so delighted to be speaking very quickly, trying to link all the wonderful ideas that we have just heard in the introductory session and the speeches by President of Estonia, by Mayor Bloomberg, and by our regional director. Try to bring together NCD's mental health megatrends, link to the 4 other hearings that we are having in this EPW 2.0 series, and try to distill some ideas that can take us into 2 major documents that I invite every participant here to come and join us in formulating. One, the NCD and mental health content of EPW 2.0, as well as entering the strife, entering the negotiation for the development of a very powerful UN political declaration at the 4th UN high-level meeting on non-communicable diseases and mental health. And doing that, I would like to start from a very strange place. In the area of dementia, which is not often mentioned when we talk of prevention and control of NCDs and mental health, dementia seems like an end state that is very far, very distant. We are all aware that it is indeed, with an aging society, a growing burden of health systems, of families, and of individuals. But it serves for us as a wonderful illustration of how NCDs and mental health come together with the other issues being discussed in EPW 2.0. As recently as last August, a commission of the Lancet on the preventability and treatment of dementia focused on 14 risk factors and found that this vast burden of dementia is 45% potentially modifiable. We can potentially we can potentially avoid up almost half of this large burden of dementia. And so it's worth us, as we discuss these megatrends, dissecting these 45 potentially modifiable elements in the problem of dementia. And the Commission gives us a very interesting life stage approach of analyzing the risk factors. In early life, it looks at people who are deprived of education in early childhood stimulation and in infancy, childhood, and teenage, people who are denied an education, eventually the society pays the price because of the higher level of dementia that they will suffer. In late life, social isolation and air pollution contribute significantly to dementia. In midlife, hearing loss, depression, and traumatic brain injury contribute to dementia. And a group of NCD-related issues, the risk factors such as smoking and excessive alcohol, physical activity, but also the conditions of high cholesterol, diabetes, and hypertension. Indeed, if we group these from a life course into a more traditional organization and categorization, the lower left-hand corner, air pollution, less education, social isolation, 13% of dementia can be avoided if we address the social and environmental determinants of NCD, mental health, and dementia in particular. At the top, we see depression, traumatic brain injury, and the sensory stimulation, visual loss, and hearing loss. Another 15% of mental health and neurological and injury-related issues can be potentially part of our project to reduce dementia in the European population. And on the right-hand side, this cluster of traditional non-communicable disease risk factors and conditions are not just targeted at the traditional indicator of premature mortality, but they are also reducing in total up to 17%, have the potential to reduce in total up to 17% of dementia. To me, this commission and its findings serves as a wonderful weaving together of the issues of demography, the issues of mental health and neurological diseases, the traditional risk factors for non-communicable disease, and the importance of addressing the social and environmental factors that are important in public health. And how about we look at one of these issues, one of the most difficult ones to tackle. About 10 years ago, we in the WHO European region produced in 2014 a model of the future burden of obesity and obesity-related diseases in the WHO European region. What has happened, and we said then that none of our countries would be achieving the target of halting the rise of obesity. Sadly, in 2025, as we celebrate the 10th anniversary of this paper coming out, we proved to be, unfortunately, very correct. We have not had any good evidence that countries have stopped the rise of obesity. We have hopeful signs in France and Spain that there is slowing of the rise of obesity, but in the immediate future, we are interested in explaining what is happening in France. Is it a saturation of the population? All the people who can be obese have become obese? Is it true their highly exemplary nutrition and physical activity related and addressing the obesogenic environment? Is it possibly experimentation or use of the new drugs, the semaglutides and these family of GLP-1 agonist receptors? The explanation is not yet there, but at a regional level, we are still finding a huge problem. And even though we have this huge problem, another Lancet commission, of which I was proudly a member and a commissioner, reported only 6 days ago, defining and creating new diagnostic criteria or proposing new diagnostic criteria for what we called clinical obesity. There is so much obesity around, defined traditionally by the body mass index, that it is difficult to discern this continuum that exists between people who have high body mass index, clearly face a higher risk of future disease, but at the same time seem to be quite functional and in good health. So how do we distinguish this group who is at high risk and needs concentrated prevention versus that group that has the clinical manifestations of obesity and the clinical consequences and needs management and treatment? And indeed, it will be quite useful for people in this audience to familiarize themselves with the report, with this proposed new classification of preclinical and clinical obesity, looking at how it affects people across the life course, connecting to the issue of demography that we will be talking in each of the hearings, bringing together the continuum of prevention and care that is going to be a great theme in my presentation, but also looking at one of the many manifestations of the mental health interlinkages between psychological and economic well-being on one side and chronic physical disease on the other. The issue of well-being, the issue of stigma is an issue that is inherent to every chronic disease, every physical disease. Another way in which NCD and mental health come together. So as we think about the big trends and we try and dissect any of multiple issues that we could bring, but we have limited time, we also have limited time in order for us to achieve the targets that we have set for ourselves for 2030. Remember, in targets in the Sustainable Development Goals, we have committed ourselves to reducing the premature mortality from non-communicable disease, to advancing and promoting mental health and well-being, to reducing the use of reducing substance abuse, including narcotics, and the use of alcohol, and to reducing road traffic injuries, all targets that we need to go forward and accelerate our progress. There is no spoiler here. I think everyone who is interested enough to attend this meeting knows that we are not going to make it unless we really increase the action and progress that we are making. If I just look at one facet of this, which is very telling, we talk about 90% of deaths in our region coming from non-communicable diseases, but the natural question is, can we prevent? Can we treat populations in a way that avoids? And we have tried and will by March of this year be producing a report that identifies how much non-communicable diseases we can avoid through traditional prevention, smoking, alcohol, nutrition, physical activity, and how much non-communicable disease mortality we can reduce by treatment. And by treatment, I mean treatment across the continuum. On the one hand, things that we would normally do in community care and in traditional primary healthcare centers, for example, the monitoring of hypertension, through to the acute lives-saving interventions that we can offer in the early minutes after a myocardial infarction or a stroke, or as a recent cancer survivor myself, by providing rational chemotherapy in the countries. So if we had to classify the countries of Europe by preventability and treatability, we find a very interesting gradient, and that could lead us to many hours of debate. The average of the WHO European region is in the center, but we see that there is a very wide range of preventability and a very wide range of treatability that we can observe in our region. And indeed, there are all these countries, both the ones that are below the European average and those that are above, can improve their progress and work to increase the implementation of the best buys, especially focusing on those what we call the quick buys, those best buys that will give you a result in the within a 5-year period, the period of a Minister of Health in office on average. But we cannot just look at 2030. We need to look at longer distance. We need to develop a vision by 2050, because many of the overall drivers that I will quickly review are things that are not going to change fundamentally by 2030, but that we need us as a European region to commit to a generational approach. And I would propose that as we develop the political declaration for the UN high-level meeting, we think ambitiously and we focus on a possible 50% by 2050, a 50 by 2050 target to reduce the premature mortality from non-communicable disease by 50% by 2050. We are looking at the data on preventability and treatability, and we are seeing that the 29 most advanced countries in the European region are already on track of achieving this target by 2050. Theoretically, such a target is feasible. We need the political clout and the political will for the next UN high-level meeting to be committing to an ambitious target such as this one. But in order to achieve such targets, there are many things we must address. Our regional director, Hans Kluge, mentioned the importance of commercial determinants. And commercial determinants have been the subject of much debate and much study in our region. 7,400 people die every day in our region because of the health-harming industries, tobacco, alcohol, unhealthy diets, and fossil fuels. We also have commercial determinants in, for example, the whole continuum of policy, prevention and treatment of cancer. And this was also the subject of a series of reports we published 2 years ago. In mental health, the link between social media, digital determinants, and the mental health and young people has already been mentioned by a number of people. Commercial determinants are here to stay, and as the techno-capitalists, as they have been called by one author, start to increase their influence in society, there is even a new wave of corporate interests that we need to be able to regulate. Equity is an issue. We have strong differences between East and West in our region. Higher mortality in the East, more cardiovascular disease in the East, more cancer in the West. In both, we can get an absolute reduction in premature mortality and a faster reduction in the East to level down and bring greater equity between East and West. Hans has already mentioned men die young, women suffer longer. Both are important public health issues relevant to NCD and to mental health. Within countries, wherever we have evidence, unfortunately, we don't have enough evidence, and this must be part of our commitment to increase the evidence. We can see gradients of inequity in both non-communicable disease and mental health. And finally, we have precious little evidence that our interventions can consciously and intentionally bring greater social justice, reduce this inequity. And it is a challenge to each of us working in non-communicable disease and mental health to actually document these effects, to use implementation research, natural experiments, whatever cohort studies, whatever designs can be used in order to document how our interventions are contributing towards evening the gaps and building a more equitable society, a true economy of well-being. We seem also to have forgotten the lessons of COVID. We talk about cycles of panic and neglect, but also it's a book of forgetting, to misquote Milan Kundera here. There's a book, the lessons of COVID. COVID has delayed by at least 2 years our attainment of the 2030 targets by consuming and killing off so many people who were made vulnerable by chronic disease, by non-communicable disease. The linkages between the vulnerability of chronic disease in the context of emergency and the added layer of a pandemic must be a lesson that we learn, and not just for pandemics, but for the whole flood of the permacrisis and polycrises that we are seeing. And we are very happy that in Preparedness 2.0 in our region, there is conscious and direct reference to both non-communicable diseases and mental health. But the question we need to ask ourselves in EPW 2.0 and the political declaration is, are we committed to including these two within the emergency preparedness plans? And I think if we looked, we would find that there is precious little conscious planning for NCD and mental health services during the time of emergencies. And while not everything in climate change is a crisis, there are many potential co-benefits. Food systems is just one example, that spaghetti of connections between food producers, retailers, marketers, consumers, and multiple researchers, academics, corporate interests, and public interests. Just that one dimension of climate change, the mitigation that can come from the emissions in health systems themselves, there's a lot of co-benefits that we can still work on and improve, even as we are recording epoch-level records of temperature rise. So my concluding slide. If we had to take 2030 and 2050 as a continuum, what would be my checklist for inclusion in the UN political declaration? It is my checklist based on a number of consultations that we have had over the last 6 months. Nearest to 2030, we need to accelerate what we already know. The best buys are there. Let us implement, not just measure adoption, but also enforcement. Focus on the quick buys, those that can give us a result in 5 years. Increase our data for impact, use predictive tools, new ways of using surveillance, delving deeper into the inequities within countries and between countries. Work to provide care across the continuum. Yes, strengthen primary health care, but also within our universal health coverage to bring in those essential tertiary care services that can save a lot of lives. Innovate, innovate, innovate. Social innovation, financial innovation, not just technical innovation. Look into Preparedness 2.0. We have the mandate now. We need to make the plans to incorporate our responses to NCDs and mental health. We have a resolution now for social participation. In this audience and in our meeting forthcoming in Athens, we are bringing in people with lived experience. I like to present myself as speaking as a director in WHO and an expert in the field, but also an expert from my experience of a very aggressive cancer in recent times. And I think we use the patient as expert more effectively, both at the regional level as well as at country level. We need to regulate and address the commercial determinants, the ones that are already there and the new ones that we see developing. Our struggle for social justice and the economy of well-being, addressing the social determinants, must remain an integral part of our work on NCDs and mental health. And finally, as we act on climate change, the co-benefits are so clear and so strong of thinking always about aspects ranging from the food system to climate anxiety and its impact on mental health, that I think it completes a very neat basic layer of what we would need to commit to as we go forward to the UN high-level meeting and the political declaration. Thank you for listening. Thank you for the partnership.
Thank you, Godin, for your very rich presentation and for framing the situation in terms of non-communicable diseases, mental health, and the megatrends, and for giving us a way forward. Now, we've invited you here for a hearing, and it's very important for us to hear what you have to say. We're going to introduce a tool which we'll be using today and throughout the hearings called PARA. This is a tool we've developed internally to collect and synthesize your inputs. In a minute, we will share a QR code and the question, as well as a link in the chat. So we would like you to take a time to answer the following question. Describe up to 3 strategic directions or priorities that should shape our collective health agenda for the next 5 years to help us meet our commitments on non-communicable diseases and mental health, and to contribute to a region that is equitable, health promoting, and prepared. We're going to take a brief 5-minute break to give you time to both answer this question and to stretch your legs. But we want to be sure you're back in 5 minutes because we have an exciting lineup of speakers. I will just make one comment about PARA. While we ask for your name and your email and your affiliation, this will not be linked to your responses. Your responses are anonymous. And so we really appreciate the input you provide, because this is how we're gathering your voices and incorporating them into our work going forward. With that, I would like to take a 5-minute break. Thank you again, Godin, and to our speakers, and see you in 5 minutes. Welcome back to the studio, and thank you for giving us your comments in para. We'll be leaving it open for about 10 more minutes. This will allow us then to synthesize the results while our next panel of speakers is presenting. And you will hear back from your colleagues and from everyone else online at the end of this session. So we've invited several speakers to join us virtually and to answer a similar question to what we just asked you. Our first speaker is Kumanan Rasanathan, Executive Director of the Alliance for Health Policy and Systems Research at WHO headquarters. Dr. Rasanathan, in the context of the megatrends mentioned earlier, what do you see as the key strategic directions or priorities for the next 5 years from a health policy or research perspective to help us achieve these goals?
Good morning, everyone, and thank you, Alison, and particular thanks to Hans and Gordon for this great privilege to address this audience. We've already had some fantastic speakers this morning. I'd like to propose 3 suggestions for key strategic actions: health taxes, steering the digitalization of our societies towards equity, and finally, realizing the health and equity co-benefits of climate change mitigation that Gordon already referred to. So firstly, to health taxes. We know they work. We know they improve health. We have all the guidance, but we're not using them enough. Whether that is on tobacco, alcohol, sugary beverages, or increasingly other areas such as fossil fuels. The recent Bloomberg Task Force on Fiscal Policy for Health reported that a one-time tax increase on tobacco, alcohol, and sugary beverages of 50% in prices could raise $3.7 trillion over the next 5 years, 2.1 trillion in low and middle income countries, and 1.6 trillion in high income countries. We often are worried about the fiscal situation for health, but this is a crucial tool to address the commercial determinants of health and to improve health and health equity. But we then need to be honest about why we haven't made the progress in using this vital tool that we would like. So we need to be thinking about framing. We need to be thinking about the obstacles. How do we mobilize the coalitions? We also need to address the legitimate concerns of both communities and policymakers about why they're not implementing these taxes at the scale that is required, including a realistic and credible understanding of how to address equity concerns in terms of consumption taxes. Secondly, we need to steward the digitalization of our societies and of our health systems towards equity. We've already heard a lot about this morning, but we need to do this for 2 reasons. One is to support chronic care and patient empowerment to address non-communicable diseases and mental health. But secondly, to address the mental health impacts of digitalization, especially in our children and young people. And we've already heard President Karas say how we need to do this in a nuanced way that balances interests. We should be excited about the possibilities of generative AI. We know that in the last 2 years, it's passed medical licensing exams. It's outperforming human doctors in so many areas. It can speak multiple languages. It has superhuman persuasive abilities. It can show empathy. It's often been shown to be preferred by patients, even for mental health counseling. The promise of a clinician who doesn't take years to train, costs less than $1 an hour, is prepared to work in rural areas, makes less errors, and has up-to-date medical knowledge is really within our grasp. But the concern that we must have is this: will this really improve equity? Will it really be benefiting the people who currently don't have access to non-communicable disease and mental health services? If we leave it to the norms in our society, it won't. It'll just exacerbate inequities. So we need the state capacity to steward this towards equity. And the same applies in terms of addressing the mental health impacts of digitalization. This can not only be done by the health sector, obviously, but we cannot only have this mantra of health in all policies. We need to make it real, and we need to consider why the health sector has often not been as successful as it should in calling for such action. And then finally, we have been talking about the health co-benefits of climate change mitigation for my entire public health career, which is why it's so disappointing that we haven't seen the achievable transformations in energy, transport, food, and agriculture systems, which will not only mitigate climate change, but will have such benefits for non-communicable diseases and mental health. But again, maybe we should be honest. Is co-benefits an understandable concept? Do we have the capacities in the health sector to make the case for all the progress that we've made in taking health to climate change discussions? We can often still be seen as peripheral. We should not think about health exceptionalism. We should not claim that health is the only consideration in our societies. So this again is around improving health and state capacity, addressing social, commercial and social determinants of health, to really reap the benefits of the available technology to drive these transformations in societies. And these can also be the quick wins that Gordon presents. So finally, of course, being at the Alliance for Health Policy and Systems Research, I think that research and learning is crucial to drive each of these three actions. It's not research and learning necessarily on the what. Countries and communities need support on the how. They need implementation research. They need policy research. They need natural experiments and their evaluations. They need research that engages with their realities, their political economies, that is co-created by policymakers, by implementers, and communities. So I'm pleased to say that these three strategic actions I'm advocating mapped to three of our 5 focus areas in our strategy. So we look forward to playing our part to support our WHO colleagues in their collaboration with countries in the European region, which has so much expertise, so many assets, and I'm sure can really make that rapid progress that Gordon is calling for in the next 5 years towards 2030 on non-communicable diseases and mental health. Thank you.
Thank you, Dr. Asanathan, for your perspective. We took many points from your very comprehensive inputs, which I hope can be inspiring others to contribute to the PERA. So a reminder that PERA is still open, but also for the breakout sessions later on. I have the pleasure now to go to the next speaker, who is Saliha Karimbayeva, a Deputy Director of the Department of Sanitary, Phytosanitary and Veterinary Measures at the Eurasian Economic Commission. Deputy Director, thank you for joining us today. Your work has a lot to do with promoting and fostering intersectoral and cross-border collaboration. And taking from your perspective and from your work, if you can kind of guide us into how can cross-sectoral, cross-border collaboration bring benefits to addressing megatrends in the non-communicable diseases and mental health. Over to you. One minute, Dr. Karimbayeva. Unmute yourself. We cannot hear you still, so if you kindly try to unmute yourself.
Thank you very much for the opportunity to share ideas for our future joint actions to address NCD and mental health challenges. As a supranational economic integration organization, the Eurasian Economic Commission works closely with the ministers of economy and business communities. It is crucial for us to safeguard public health while ensuring the free movements of goods, services, capital, and labor, and promoting stable development to raise the living standards of our member states. In line with the priorities of our member states in promoting health and addressing NCDs, we jointly with our member states are committed to conduct research on the socioeconomic factors contributing to NCDs, develop harmonized NCD prevention strategies, improve regulations to mitigate NCD risks. We propose to focus our joint efforts on the following areas. first food safety standards and nutrition. In the Eurasian Economic Union, we prioritize the harmonization of food safety regulations with European directives and international guidelines, including the WHO's recommendation and Codex Alimentarius standards. However, some global indicators, such as trans fatty acid limits, remain merely advisory, leaving countries to weigh economic interests against public health. To address this, we advocate for stronger global leadership and mandatory measures in food safety. In this regard, our primary concern is the health of children, as habits formed early in life significantly influence long-term outcomes. High consumption of sugary, fatty, and salty foods among children leads to conditions such as obesity, micronutrient deficiencies, and hypervitaminosis. Addressing these issues requires targeted NCD strategies. Second, mental health. The increased use of digital devices among young population highlights the need for guidelines on screen time and the psychological impacts of digital engagement. Establishing standards for scary toys and violent computer and mobile games is another critical step in fostering mental well-being. Tobacco control. The Eurasian Economic Union has made significant progress in combating tobacco use. Over the last decades, our member states have enhanced regulations, leading to a reduction in smoking prevalence. Yet, new challenges emerge with the rise of alternative nicotine products. To tackle this, we propose emphasizing the need for comprehensive regulation of emerging products. Climate and health. The intersection of climate change and health is another critical area. While the Eurasian Economic Union prioritizes carbon agendas and climate action, the health impact of climate change are insufficiently addressed in strategic documents on economic integration. Also, we encourage WHO to incorporate stronger emphasis on these linkages within the second economic program of work. We view EPW2 as a platform to align our efforts with WHO's goals, creating sustainable health policies. Together, we can tackle NCDs and ensure the well-being of our future generation. So we look forward to our discussions, and thank you.
Thank you so much for your responses. And indeed, these are all tasks we must take on together, and the importance of working across borders and across sectors is essential. Next, I'd like to go to our next speaker, Professor Anna Gilmore from Bath, University of Bath, the United Kingdom. Professor, thank you for joining us. Indeed, commercial and social determinants are a huge barrier to achieving our health goals. I'd like to give the floor to you and tell us, what do you think we can do in the coming years to address these determinants of health? Over to you.
Thank you so much. Good morning, everyone. It's an absolute pleasure to be here. So simply by virtue of the vast scale and enormous cost to society that they cause, I propose that we prioritise commercially driven health harms, what we now call the commercial determinants of health, and Gordon has touched on those already. And within that area, I've got three primary recommendations. First, we absolutely need to prioritise what I call the risk factor approach. So in our Lancet series on the commercial determinants, we showed that between 60 and 80% of global NCD deaths are attributable to just 4 products: ultra-processed food, fossil fuels, tobacco, and alcohol. Until now, we've really underestimated the health impact from fossil fuels, particularly through air pollution. And those globally are on a scale now similar to tobacco. So if we want impact at scale, and in the short term, we must target those products. Within that arena, the options for doing that range from population level interventions to individual level interventions. We must prioritise the population level interventions for a few key reasons. These are the ones that will have the greatest impact, but they're also far more likely to reduce inequalities. And thirdly, they're going to be cheaper to implement. Okay, so this is policies that will change environments. And the approach to this, I think, is simple. We take the same approach across those commodities. We need to address the 4 A's. Reduce affordability, as we've heard from Kumran, not only through tax increases, but by stopping subsidies. There are still vast subsidies, in particular for fossil fuels. We need to reduce attractiveness. So this is through mandatory warning labels, but also advertising bans across the board, including why are we still advertising SUVs, cars, flights, holidays? You know, the carbon, we also need high carbon advertising bans, and we need to bring those into the health arena. We need to reduce accessibility and availability of these products. This is through reducing the number and location of outlets, reducing the prominence of unhealthy products within those stores. And then I would add to that the need for clean air zones or ultra-low emission zones. We're seeing significant positive impacts on health from those at scale. So while those policies are absolutely vital, we've also learned from tobacco that in the long run, they're not going to be enough, because the global decline in cigarette consumption has now stalled. And the reason for that is we haven't changed the incentives in the system. And so the tobacco industry has fought back. So my second recommendation is that we must go well beyond those risk factors to address the underlying drivers of the commercial determinants of health. And in doing that, we need to recognize that the commercial determinants are not separate to the social, political, and economic determinants. They're part of them. This is not a fight between different types of determinants. In fact, it's changes to the political and economic system that have driven commercial harm. Okay. Sometimes I think this area can feel a bit overwhelming, and we need to clarify our asks. We'll shortly be setting up a website where we're going to use the Lancet model to help us identify solutions in this area. But let me flag some positives, some priorities that I believe will have the greatest impacts. First, we need to reshape our economies. As we saw in the WHO Council on the Economics of Health for All, we need to move away from GDP to economic models that prioritize well-being. And the reason for that is that will then reshape all the policy making that falls underneath that. Because if our priority is no longer to maximize GDP and growth, but to increase well-being, we will make fundamentally different decisions. And so it will make it far easier to implement the health-oriented policies that we need. Second, we need to improve governance. And our priority here is to improve understanding of conflicts of interest across the whole of government. So in tobacco, we've had Article 5.3, and within many health ministries, that works really well. But outside health ministries, there really is no understanding because conflicts of interest are not well understood. So we've got to work really hard to simplify that agenda and make sure that that is understood. And it simply means that if I'm selling a product and making profit from a product, I should not be at the table when policies on that product are being developed and discussed. It also means that partnerships, including multi-stakeholder initiatives with health-harming industries, are rejected. Where there is a conflict of interest, the evidence is clear that multi-stakeholder initiatives do not work, and so we need to move away from those. Thirdly, we've been hearing about misinformation. We also have a problem with disinformation. And in part, this is because corporations are still funding science and public information. And the evidence is now clear that commercial funding of science and educational materials leads to misinformation and disinformation, which slow progress in addressing NCDs. At the same time, commercial funding of science is increasing while public sector funding is stagnating. So we need to address our funding systems of science if we're to ensure that science functions in the public interest. And that leads to my fourth recommendation, that we need to move towards what I call a polluter pays approach. And this is to ensure that commercial actors meet the costs of the harm they cause. They pay for the science that we need, but we need safeguards in place. So let me explain. Right now, health harming industries are causing huge harm. Think of all the hospital admissions. But they're not paying for the costs of that harm. We're paying for that. So they remain incentivized to cause that harm. So we need to address that. And a key way to do that is to ensure that they're paying for it. Taxes go on consumers. We need a different approach. So the charges go on corporations, and that's called a polluter pays approach. There are some small models in place. Thailand has a tax on tobacco and alcohol companies, for example, to fund research and health promotion. There's similar in California. We need to better understand and research those models so we can, implement them more broadly. But any model must have safeguards in place to ensure that it prevents industry from misusing those payments to secure influence. Okay. Finally, my third recommendation is really simple. To enable all of this, and most of the recommendations we've heard so far, governments must use their power. They must regulate and they must enforce that regulation. We know many of the policies that are needed. They've been set out for years. We hear always about the problem of interference. I've done so much research on this, but at the end of the day, governments do have power. They can regulate, and it is time for them to use that power and regulate in the public interest. If they don't do that, health systems are simply going to become unaffordable. Thank you.
Thank you, Professor Gilmore, for this very comprehensive overview of the priorities, of suggesting priorities for action. I hope these have resonated with our audience in this hearing. But if I can pick up one, is the reminder that you bring us that past achievements are not for granted, and that we not only need to continue the fight against, for instance, certain all determinants, but we also need to innovate and be flexible, creative, and innovative in how to address those new, the continuation of those determinants and probably the acceleration of their impact. We are now going to Dr. Claudia Marinetti, who is the Executive Director of Mental Health Europe. Mental Health Europe is the largest umbrella organization for mental health in the European region. And I'm inviting her to share her thoughts on the topic of today's hearing, considering the megatrends discussions. Claudia, what do you see as the key strategic directions or priorities that must be addressed in the coming years to advance mental health and well-being in the region? Over to you.
Thank you very much, and thanks for this opportunity to speak on advancing mental health in Europe. We know that mental health has become really a defining challenge of our times, and it's shaped by megatrends amplified by the public crisis, be it the ongoing impacts of the pandemic, climate change, geopolitical instability. To advance mental health, it is important for it to be considered alongside non-communicable diseases rather than a part of them. And here I think then we are on the right path. Mental health is a story on its own that needs dedicated, bold, and transformative action. I think that to make meaningful progress over the next years, WHO Europe should prioritize 3 key strategic actions. One is on human rights-based and recovery-oriented care. The other one is on co-creation of policies and practices, and then addressing the social, economic, and commercial determinants of mental health. First, we must center mental health care on human rights and recovery. The future of mental health care must move away from institutionalized and paternalistic models and towards a recovery-oriented approach that prioritizes dignity, autonomy, and participation. This means really embracing human rights at every level of care, ensuring the services are non-coercive, that they are person-centered, that they are inclusive. WHO Europe must continue to lead by setting standards for rights-based care, promoting deinstitutionalization, and supporting nations and member states to invest in community-based services that empower individuals to reclaim their lives. It is important that there is an alternative and that there is really a move, a transformation of our system, so that there is a base where people can go, so that people don't fall into the cracks. And we need to remember that the recovery, it is not just about managing symptoms, it is really about flourishing. That must be our goal, and that is what can lead also to stronger and more cohesive societies. The second focus is on co-creation. Co-creation must really be and guide our policies and practices. Those with lived experience and living experiences and their supporters, they're not just beneficiaries of care or targets of policies. They are experts on their own rights. It is very important also, I think, that we move away from this idea of empowering people. I think that we need to move towards an understanding of co-creation, which is about sitting together with all the key actors, being able to value each other's expertise and to really work together to bring about change. And by valuing diverse perspectives, we can create mental health systems that are more effective, equitable, and resilient. And true co-creation builds trust, reduces stigma, and aligns interventions with the real needs of the people that we serve. Let's also remember that innovation is not only technological. I think the co-creation can bring really strong innovation to the way that we work. And third, we must address the socioeconomic and commercial determinants of mental health. We have already heard this coming out quite often, which is a good sign. We know that the digitalization, that declining social cohesion and economic insecurity are reshaping the mental health landscape in profound ways. WHO Europe must act as a catalyst for change by advocating for policies that mitigate these risks. And this includes, among others, promoting digital inclusion, but at the same time, making sure digitalization does not isolate, especially when it comes to providing care via digital means. We also need to safeguard mental well-being in an online age, also very much making sure that the commercial interests are not taking over our well-being. We need to foster programs that combat loneliness and strengthen community bonds. We need to integrate mental health into socioeconomic policy, recognizing really the financial strain and inequality are fundamental drivers of mental health disparities. And we need to work within the educational systems to really create resilient generations to come. In terms of the commercial determinants, we have heard a lot. I just wanted to point out that, of course, we need to reduce access to products that are not good for our health and mental health, but at the same time, we need to make sure that we are providing affordable alternatives. And also need to make sure that we make healthier alternatives attractive. And here, we really need to work on our communication. We know what communication is doing and has done and is doing to our societies. I think we need to get this right, to turn the narrative around mental health and to turn the narrative and to really create more trust and more unity within our societies. Mental health cannot be separated from the social and economic context in which people live. I think that these three priorities, human rights, co-creation, and socioeconomic and commercial determinants are not just strategies, they are imperatives. Together, really, they can offer a roadmap for fairer, more inclusive, and resilient mental health systems and healthier, stronger, and safer and just societies. I know that the challenges that we are facing are great, but I think that if we center our work on dignity, collaboration, and the social realities of our time, we can really deliver transformative change for people and communities. So let's really rise to this moment and let's embrace this with courage and with a lot of commitment. Thanks.
Thank you, Dr. Marinetti. Thank you, Claudia, for your thoughtful contribution. If I have to pick up from your comprehensive recommendations, I'd like to highlight the importance of co-creation, looking at persons with lived experience not only as at the end side of our collective efforts, but as equal part of the processes. And we heard also from Dr. Gallia his experience as a cancer survivor. So the
importance of the co-creation cannot be overstated. And that brings me to our last speaker. I have the pleasure to invite back Ms. Judita Prndrecaj, who was with us in the high-level panel. And Judita gave us a very strong plea for involving the youth perspective and looking at it from the youth perspective. So while you were very articulate into making that plea, Judita, I'd like to also remind the audience that young people are among the most affected from the series of crises we are experiencing now. And while in your previous plea, Judita, you elaborately talked about and you called upon authorities, upon governments, upon different stakeholders, I'd like to see how do you think young people themselves can contribute to keeping those authorities, stakeholders accountable for promoting healthy life choices among young people for securing a better future. Over to you, Judita.
Your youth are not just the future. They are present force driving change. Their energy, creativity, and digital fluency make them powerful agents of transformation, perfectly positioned to shape and implement the vision of European Program of Work too. By engaging in decision-making, advocating for the issues that matter to them, and leading with innovative ideas, they ensure that policies are not only forward-thinking, but truly reflect their values and aspirations. When young people are empowered to take ownership of their future through their leadership, they inspire not only their peers, but entire communities, proving that a unified, passionate youth movement is key to turn vision into a reality.
Thank you.
Are you hearing me or no?
Yeah, we can hear you. Please, you can go on. I'm not sure if, yeah? Yes?
Yeah, so I should go on with the role of governments, international organizations, and other stakeholders play in promoting healthier lifestyles choices among young people, or not?
Up to you, but what we would like to hear, I would focus on one point that you very importantly made. You said youth are ready to and willing to take ownership for the future, and this is if you can unravel that into how can we hold then governments and other stakeholders, international organizations as well, responsible for making sure that this future
by discuss their realities of daily life. And so through different organizations, so they can advocate for their rights and health, and that's all.
Excellent. This is an excellent answer, actually. So thank you very much, Judita, for also accepting a question that was not already prepared. Over to you, Alison.
Thank you so much, Lydia. As we know, responding to these complex challenges require comprehensive and integrated approaches, and this is what we've heard, but also it requires keeping people at the center. So I think we can go now to, I want to talk about Andrea Vianello. Andrea Vianello is a journalist who lost his ability to speak after suffering a stroke. But thankfully, due to rapid response and to the fact that he received the care he needed so quickly, Andrea is living with a healthy life and he has received the rehabilitation services he's needed. But let's hear from Andrea.
Io non riuscivo a dire i nomi dei miei figli e insomma è una cosa brutta. Al punto che io pensavo che quando le persone mi vedevano io fossi un mostro, perché in realtà non si vedeva niente, perché io apparentemente non avevo dei segni dell'ictus. Ho perso la parola per me è sempre stata un po' la bandiera, la mia identità, l'arma del mio mestiere. E quindi c'è stato un periodo molto molto complicato, molto periglioso, in cui io con la riabilitazione ho cercato di rimettere a posto le parole. In ogni secondo, piccolo secondo, noi perdiamo un pezzetto del nostro cervello quando abbiamo questo problema. Ho avuto la fortuna che tutto, diciamo, è andato bene da un punto di vista dei tempi, del tempo che mia moglie che è stata veloce, loro che sono venuti subito e ho trovato poi i medici giusti. forza della riabilitazione si può uscire, ecco, magari non come di prima, ma come una persona vera che lavora. L'ictus non è prevedibile, ma si può prevenire. Ictus fa paura, ma bisogna farci i conti.
Stroke is a major cause of death and disability in our region, but as we've heard, with the right prevention and management, we can reduce strokes and reoccurrences. I hope you are all inspired by Andrea's story. Now, we've been listening to our panelists. Godin has been working busily in the background with Para to synthesize the inputs you've provided. So I'd like to give the floor back to you, Godin, to share what we've found. Over to you.
Thank you very much. Just in time, I am, if I can do the same thing as the last, hopefully we will be able to share faster. May I ask if you can see this?
Your screen.
And if it is in full screen?
Yes.
Perfect. As you can see, in the time that I was running the summary and the report, there were quite a number of responses, a high response rate from those who registered, meaning that's 80% of the total number of allowed responses by the number of people who joined. We had about 2 responses, and out of the 750 who are attending, 275 attendees put their ideas forward. There's no way of summarizing all of that. I will just give you a glimpse of the headings and the general content of what people gave us as you go into the breakout sessions. So a group spoke on integrated care, the importance of training healthcare professionals, promoting digital health for chronic disease and mental health. Conflict of interest frameworks, documenting the economic costs of inaction. Policy guidance by WHO, regional guidance together with countries and guidance on resource allocation. The integrating of specifically mental health services into primary health care and policies for addressing youth and elderly mental health issues. Organization of regional health promotion efforts and supporting the implementation of the WHO best buys. Developing climate resilient health systems, integrating health, NCD and mental health areas into climate policies. Strong comments, multiple comments on the digital transformation in health systems and the adoption of digital technologies, together with equitable access. The integration of health literacy into the national education systems with various comments on behavior and cultural insights, even promoting intergenerational learning. Our workforce colleagues in health systems will be happy to see a family of comments that related to workforce planning, training, and retention strategies as part of creating these resilient health systems that will respond to non-communicable disease and mental health. I can see the voice of people with lived experience because this was one of my suggestions, the importance of person-centered care frameworks. My own nurse navigator in my cancer journey was a tremendous boost for my ability to cope with the challenges of a highly specialized and often siloed health systems. Integrated care as a very important. A strong voice, probably related to a strong presence. We are happy to see the voice for youth participation and health governance, including within WHO health governance, and the funding of initiatives. So funding, institutionalizing, and involving young people, and I would extend that to people with lived experience. Emphasis on the dignity and quality of life for the elderly. Strengthening WHO's role in facilitating multisectoral collaboration was the theme of another set of comments, and that in order to seed your further discussions in the breakout sessions is a very quick pick from the list of priority actions and themes that you asked of WHO. But I think as we go into the breakout, we will need now to also focus on what you can do in countries concretely, or between countries concretely, within the themes of the breakout. Thank you. Back to the studio.
Thank you so much, Gaudin. And thank you to everyone for your inputs. And now that you've had a chance to see how PARA works and to contribute your ideas, we want to hear more from you. So this is, again, an opportunity for you to tell us what you think should be prioritized in EPW2, and also what we can do collectively going forward. And this is to help countries in the region tackle the most pressing health challenges. So we encourage everyone to take this opportunity to join one of the breakout sessions where you can discuss these issues in more detail. So we have 6 sessions that are all accessible from the lobby. The link back to the lobby will be pasted in the chat by our colleagues. And so once this session is over, so please navigate back to the lobby and pick a breakout session to join and follow the link into the chat, or you can use the same link as in your calendar block or email. We are posting the breakout sessions on the screen, and I also want to remind you of the upcoming future hearings, as this is the beginning of a series of 6 hearings. So before you go, we'll take a few minutes and we'll join. The sessions will start at 11 o'clock Central European time. But before you go, we want to thank you all for joining us today, for contributing to the development of the European Programme of Work 2. Thank my colleagues and everyone in the studio. I want to thank our translators, interpreters, and everyone who made today such a rich and interactive experience. So please join us in the breakout sessions and give us more of your thoughts. Thank you.
Thank you.